So chest pain management in the United States is very, very costly and very, very inefficient. It's also quite variable depending on which emergency provider or cardiologist is doing the workup. So put it into perspective, 8 to 10 million patients present annually to the emergency department. For a chief complaint of chest pain, this approximates to about 10 to 13 billion dollars. Now, the vast majority of these patients, well over 50% of people who come in general to most institutions, are hospitalized for additional workup. These workups include stress tests and catheterizations, and all of these tests that we do to further work up patients who come in with chest pain can be associated with iatrogenic risks. Despite all of this, despite this huge effort that we've put forward to try to make sure that we don't miss this dangerous, life-threatening things like heart attacks, fewer than 10% actually have this dreaded condition, this acute coronary syndrome that we call it. And so there's this critical need here in our country, and across the world indeed, to try to put forth efforts to reduce unnecessary testing, reduce unnecessary admissions, all without missing any instances of acute coronary syndrome or heart attack. So one line of research that has been going on since the early 2000s and really picked up steam in the 2010s is this risk stratifying decision aid called the heart score. The heart score is a derived formula based on 5 clinical characteristics that include appropriately history, EKG, age, risk factors, and an initial troponin. Troponin is a blood test that tells us whether or not the heart is suffering from any kind of oxygen loss, which happens with heart attacks. And they found that patients who were stratified into 3 different groups, low risk, medium, and high risk, and the low risk patients had very, very low incidence of acute coronary syndrome. So they determined that patients who are low risk were safe to go home. And that incidence risk was about 2%. 2% or just under 2% had a major adverse cardiac event when they were considered to be low risk. So according to the European model, this is pretty good. And this is what is generally used in hospitals that are using a standardized approach. In the United States, however, lots of folks, myself included, are not really comfortable with missing heart attacks at the rate of 2% in the emergency department. We want that number to be less. So what researchers at Wake Forest have done is they simply added on a second troponin, a second heart enzyme at the 3-hour mark. And they found that when they just simply added a second heart enzyme onto the heart score, they were able to safely reduce adverse events in low-risk patients to less than 1%. So this is a big improvement from the heart score alone. The strengths of this is, of course, that the safety profile has got better. The downside, and the other upside is that when they conducted a randomized controlled trial, they found that they actually, compared to usual care, they found that they reduced the admission rate by 21% compared to usual care. They reduced the length of stay by over 12 hours, and they reduced additional testing by about 12% as well. So not everyone is using the heart score or the heart pathway. It's still quite variable, but institutions that are attempting to use standardized approaches, right now this is the best game in town, and this is what most hospitals are using throughout the country. So it's very good. It's very robust. The downside, however, is that even when you use the heart pathway, you're still committing about 50% of patients or so into the non-low risk category. And so what do you do with these patients? So the heart score recommends that you admit them to an inpatient or observation stay. And while that is reasonable for hospitals that have observation units, the vast majority of hospitals do not actually have observation units. Our institution at MUSC, for example, does not. In fact, only 34% of hospitals do have OBS units. The remaining 66% of hospitals are often overcrowded and don't have the resources to bring in patients for a 12 to 48 hour observation or inpatient stay. So there is this need to attempt to reduce the number of patients that we're admitting, even with the heart pathway. Now, a second line of research that I should briefly mention is coronary CT angiography. Coronary CT is an imaging technique that carefully identifies and looks very precisely at people's coronary arteries, the arteries that are affected when people are having heart attacks. And what it does is it looks and assesses for blockages and narrowing of those arteries, because the narrowing of those arteries indicates that either this patient is at a high risk for having acute coronary syndrome, maybe having acute coronary syndrome, or is it high risk for having it in the immediate future. So this has become a very strong tool to test patients for rolling in and rolling out heart attacks. The strength, of course, is that it actually has outperformed stress testing, which is probably something that folks who are not familiar with chest pain research, even those folks tend to know that there's this thing called the stress test, and it's used to work up patients with chest pain. This is more sensitive and specific than stress testing. And then the other big advantage is that it's faster. So stress testing takes 4+ hours to conduct, never mind the interpretation portion. You can get your test done and their interpretation done usually within 1 to 2 hours with a coronary CT angiogram. So it's it's a tool that's ideally suited for the emergency department. However, the downsides of it is that you just can't use it on everyone. If everyone that came in with chest pain got a coronary CT angiogram to rule out heart attacks, you're going to expose people to unnecessary risk. For example, for every 1 million patients that get a chest CT, 1,000 of them are going to actually develop cancer from the chest CT. And that's just across the board, never mind chest pain. So additionally, patients also get IV contrast when they get these CT scans, and people who are on the fence of having renal disease, it can push them over the edge and they can actually get worsening renal disease from the CAT scan. They can also get allergies from the CAT scan. And in some patients who are low risk, you can actually get false positive tests. And getting a false positive test exposes patients to more tests that exposes them to more future risk, even though they actually don't have the disease, because no test is perfect. So what we sought to do at MUSC was take the strengths of both the heart pathway and CT and try to reduce the weaknesses of them. So in 2016, we developed a novel pathway that combines the two modalities. The goal is, let's reduce unnecessary testing in these low-risk patients, and let's see if moderate-risk patients, instead of just admitting everyone who's not considered low risk, let's take this moderate-risk group and let's expose them to the CT scan to see if we can identify a population within that group who can safely be discharged home. That way we can try to reduce the number of total admissions. So as you can see here, let me go back here. So this looks very similar to the heart pathway, except in the moderate risk group, we advocate performing a coronary CT scan. And then if the coronary CT scan is negative or only shows mild stenosis, those patients can be discharged home, according to our algorithm. So in 2017, I wanted to see if we could encourage people to actually use this score, use this risk stratifying aid, because there was no way to test how often it was getting used. There was no way to really encourage people to do it. So I worked with our electronic health record team, which is EPIC at our institution, and we actually implemented a smart form in EPIC that combined these two modalities. So here on this screen, you can see a decision support tab that the providers can go into within the note and click on the different elements of the heart score, and it will spit out a patient's risk total, the heart score total, and then if it's greater than 3, it'll ask them some additional questions and make recommendations based on an elevated score, for example. So in this case, because this patient had an elevated heart score, and because they didn't have any other contraindications, which means reasons you can't do a certain test, it advocated doing a coronary CT angiogram. So the nice thing about this smart form is that it gives management recommendations to the provider in real time, and it actually inserts that management recommendation directly into the provider note. So it sounds really good. I was really proud of all the work we did to put it together. And we found that when we rolled it out after about 6 months, in 2,000 cases of chest pain, only 294 times was it used to assess for chest pain. That's just shy of 15%. So even though 294 is a lot, it's nothing compared to the total number of patients who came in with chest pain. However, what was reassuring was that in those 294 cases where providers used the heart CT smartform, we're actually able to discharge 75.5% of patients. And this was 25% more than all those previous heart pathway studies I previously discussed. So we're discharging more patients than anyone else. The other nice thing was that we found that about 52% of patients qualified as moderate risk, and of those, 2/3 of them we were able to identify as being safe for discharge. So we identified a lot more people than previous studies had for discharge. So what can we draw from this? Well, the one thing that we can draw is that smartforms are probably inadequate alone in order to get everyone on board to change their management practices. However, we did find that moderate risk does make up a pretty significant portion of our population in chest pain. And if we test its safety, we may be able to show that the heart CT pathway can effectively reduce admissions and reduce testing in a safe manner. So the next steps of the heart CT pathway here at our institution is that I'm trying to get a grant through the K-12 award to develop automated clinical decision support tools that will increase our provider use of the heart CT pathway. And specifically, ideas we have in mind are developing automated prompts that trigger providers to say, hey, this is an opportunity for you to use this pathway, as opposed to having them have to remind themselves to use the heart CT themselves. It also will incentivize providers by giving note generation assistance. So by entering in the elements of the heart score, it actually auto-populates their history so that they don't have to go through and do extra note writing. And then finally, using machine learning models to incorporating certain elements of the heart pathway, the elements of the heart score to help them make their decision to streamline the efficiency of calculating the heart score. So those are three major things we're going to be trying to do with a little bit of funding to get more providers to use the heart CT pathway. And the other thing that we need to do that we have not done yet is to validate the safety of our heart CT pathway. We've shown that it's very feasible. We've shown that we've discharged a lot of patients using it. Now we need to show that it's safe and that those patients have an acceptably low risk of having any bad outcomes. So the specific aims of our proposal is, one, increase provider use of the heart CT pathway using decision support tools to at least 70%. And I can answer questions later. I don't go into why we chose 70%, but it's based on previous studies that have increased their use of their decision support tools. And then the second aim we have is to show that this moderate risk group, this middle group of patients, as long as they don't have obstructive disease on their coronary CT angiograms, they can be safely discharged without having major adverse cardiac events. And we want that number to be that sweet spot of less than 1%. So that's kind of the short-term plan. That's what we're proposing in our immediate research. We're hoping to get funding to do that. And then my 5-year plan, which I didn't put on the slides, but my 5-year plan is then to test this heart CT pathway in a multi-site environment, and to test its generalizability and make sure that it's something that actually works in other institutions. And then my long-term plan after that is to continue to push decision support tools, automated decision support tools, to better standardize clinical practices, and not just in chest pain management, but in lots of other cardiovascular emergency conditions like AFib and pulmonary embolism and other high-impact conditions, and also become a mentor for others who are interested in research as well. So that's my kind of my initial go at research. All of it would not have been possible without the MRDA. So thank you all very much for all your support and all of the great resources you all have given to allow us to at least be able to propose this research.